In this video, I will discuss about the clinical aspects of diplopia, how to diagnose, how to localize the lesion. Firstly, we will see various types of eye movements. That is depression caused by inferior rectus and superior oblique, elevation of the eyeball caused by the superior rectus and inferior oblique, and the abduction is the result of action of lateral rectus, and the adduction is done by medial rectus, and intorsion is done by superior oblique, and extorsion of the eye is done by inferior oblique. Third, cranial supplies, that's oculomotor supplies, superior rectus, medial rectus, inferior rectus, and inferior oblique. And fourth nerve supplies superior oblique. Sixth nerve supplies lateral rectus. Third, fourth, and sixth cranial palsies can result in diplopia. See the eye movement control systems. The major centers include frontal eye field, visual association cortex of the occipital cortex, pontine nucleus, flocculus of cerebellum, and vestibular nucleus of the brainstem. All this exerts its influence on the sixth nerve nucleus, and then it is connected to the opposite third and fourth nerve by the structure called medial longitudinal fasciculus. There are other additional structures involved in the vestibulocular reflex and gaze movements. And now, in the setting of diplopia, now we'll see the third cranial palsy. It's due to paralysis of all recti except lateral rectus and inferior oblique, resulting in down and out position of the affected eye, and the pupils are dilated, non-reactive, and you also have ptosis. So all due to the impact of the sympathetic fibers of third nerve. And here the diplopia is worsened when looking onto the opposite side. Interestingly, in diabetic cranial neuropathy, the pupils are spared during third nerve palsy, and rarely the underlying condition of third nerve palsy could be a dangerous condition like aneurysm, and a prompt diagnosis is warranted. The fourth cranial palsy is due to the involvement of superior oblique muscle, and the diplopia is worse on looking down. That's classically when somebody is walking downstairs, he feels diplopia. And sixth nerve palsy is abduction is lost due to the affection of the lateral rectus, and diplopia is worsened when looking onto the same side. And now we'll see various causes of the third, fourth, and sixth cranial palsies. The commonest one is stroke, brainstem stroke, trauma, neoplasm, neurosurgery, diabetic cranial neuropathy, migraine, and aneurysm of the posterior communicating artery or posterior cerebral artery can cause third nerve palsy. Coming to the internuclear ophthalmoplegia, which is due to the lesion involving the medial longitudinal fasciculus. You see the lack of adduction to the side of the lesion, and there is a dissociated horizontal nystagmus on abducting eye. Coming to the 1.5 syndrome, so lack of movement of one eye and lack of adduction of the other eye. It is ipsilateral conjugate horizontal palsy and ipsilateral internuclear ophthalmoplegia. It's classically due to the lesion of the pons involving sixth nerve nucleus as well as the MLF. The causes of internuclear ophthalmoplegia and 1.5 syndrome. The multiple sclerosis is the most common cause of INOR 1.5 syndrome, and followed by stroke, pontine hemorrhage, AV malformation, tumors, tuberculosis, cystic sarcosis, and a few other rare causes. So to conclude, diplopia is the commonest symptom of 3, 4, and 6 cranial nerve, as well as the brain some lesions. Understanding eye movement control is essential to localize the lesion clinically. Diplopia may be also caused by certain serious conditions like aneurysm. Thank you.